thank you too for inviting me. That's right, the folder of our new National Action Plan is sitting outside on the table, so feel free to take one. Actually, I would like to take you to inter-service integration and sexual health, and by doing so, I wanted to show you an animation which didn't work out, so I will skip that and I'll just tell you something about that, but my talk is spiked by little stills from that animation, so you'll still get an impression. And also the film, the little animation is shown in the Dutch booth in the exhibition hall. So I hope you'll be able to visit that during the week. Our approach towards service integration and sexual health is somewhat of a good practice. I wouldn't say best practice, but it's working out fine. So I'd like to tell you a bit more about this. I don't have any interest to disclose, and I would, sorry. So just to go back a bit to our history, we are an inclusive and participatory society. We are one of the countries that adopted same-sex marriage as being the first of that, and we have historically a very low number of teenage pregnancies, which reflects our approach towards sexual health. We are a society with an open scope. We don't have really historically very traditional social norms, and maybe those change, but we have openness towards different opinions, and we have a high acceptance of diversity in gender and identity, sexual health orientation. Our emphasis in the approach of sexual health is always to try to be positive and to emphasize the necessity of pleasure, of sexual intercourse and sexual relationships. And in our approach, we also emphasize the need of co-creation with communities. So key in our approach is to actually link prevention, care, and cure together with the communities. And that means we have a whole lot of partners involved in our network, which are healthcare professional, patient support groups, communities and key populations, of course, national NGOs, which are involved in monitoring also and in devising prevention interventions, and of course other institutions. And together we made this National Action Plan, which was already mentioned, and I will go into that a little later. First of all, I will take you through how our system works. And this, we don't have a National Institute of Health that facilitates public health. So, but we do have a bag of subsidies which is pumped through our institution, and we finance municipal public health services in order for them to be able to set centers for sexual health care, which were often referred to as STI clinics, but they offer actually a much broader scope of activities, which I'll go into later. As you can see by the dots, that they are pretty much dispersed around the whole country. The larger spots are the centers which are coordinating all of it. By receiving the subsidy, they are also they have to give data to us. They give us data on the STI positive tests, all the tests they've done, and some data on the patients or the clients. And of course, they are needed to formulate actions and update policies. We also finance some of the NGOs which are involved in this subject, which is STI AIDS Netherlands, Rutgers, which is involved more in the sexuality division, the HIV Foundation, which is the organization which represents the interests of the patients, and the STI Monitoring Foundation. Going back to these clinics, these municipal healthcare services exploit these centers of sexual health care. This is an additional care to the primary health care which is offered throughout the country, of course. The idea is that they are low threshold and free of charge centers. They offer high quality care, and the care is given by competent care professionals. The care is offered to high risk groups only. So we have a system in by means of which we discern between high risk groups. it's an integrated service, as I said. It's not only testing for STI and HIV and treating them and referral if necessary, but it's there's also counseling for clients. We have a sexual health consultations, especially tailored for young people. These services are also engaged in outreach activities. They devise their interventions together with the NGOs, and more and more we try to involve e-health applications. And now to our national plan. I just wanted to show you some of the strategic goals, and the basis of this is that we're aiming at a facilitating government in which everybody is well informed in order to be able to make good choices about their sexual health and be protected against STI and HIV. But also, on the other hand, we want to focus on the accessibility of care. We have these nice centers, but not everybody can access them or wants to access them. So we really have to step up our actions in that respect. And also, not everybody can access these free of charge healthcare centers. So we also have to try to get this done for the rest of the people. In this slide, I'm going to give you a very brief overview of what our national plan is composed of. As you can see, we have these red and green lines which focus on sexuality, education, and surveillance and monitoring. We really believe that sexuality education, a broad education for everybody, stressing competencies is necessary for everybody to as a basis for prevent activities in the other areas. And also we believe that we need data in order to be able to make the right decisions and change our policy if necessary. And in the middle you see these 4 squares, and they represent the 4 pillars which are about prevention of and control of STI and HIV, but also prevention of unwanted pregnancies and prevention of unacceptable sexual behavior and sexual violence. So also here this reflects our combined approach. And this plan can be accessed through the internet. Now I would like to focus a little more just on the HIV control part and our goals for this HIV control. We're not doing that badly. I mean, we have a great cascade, but we want to go from a cascade, which is kind of a reverse cascade, to a continuum of care. And as you can see from this cascade, it's very clear that the first 2 pillars are the ones that we need to invest in. Our goals are to end the number, or to reduce the number of AIDS deaths to 0 by 2022, which is the end of the National Action Plan, reduce the number of new infections by 50%, and also to reduce co-infections. And of course, we like to improve the quality of life of people living with HIV and normalize testing and reduce stigma. Challenges we are faced are to really seduce more people to get tested, and also especially to seduce late presenters to test earlier and to get treatment. By this, we also have to invent, just like Hannelo showed us, we're not doing altogether too well in partner notification of known HIV patients, and we really have to find innovative ways in order to step up that notification process. We want to improve availability of customized self-testing, and doing so we want to introduce community-based testing. I'll just come back to that as well later. And we want to develop and implement sexual health apps in order to improve the the well-being of people living with HIV. To do so, in spite of our open society, we really need to have to make constant efforts. And we can only do that by involving the communities in this approach. And we really have access to these communities. That's good, but we have to put one and one together. And even though the Netherlands are a really small country, also in our case, a customized approach is necessary because we have to deal with the bigger cities in which things move faster, people are readily accessible, people can find their services more quickly, and the more remote areas or the rural areas where people also are facing, of course, their infections, and we really have to take care. We have a customized approach for them. Next, I would like to very briefly point out some challenges related to more system challenges. We're faced with some EU legislation barriers which may or may not enable us to go through our process of subsidizing NGOs and municipal healthcare centers. This will have a great impact if we can't work a way around this. Also, we have some national laws at the moment which prohibit us to test in communities. We're simply not allowed to have tests provided by peers. It always needs to be a doctor or a pharmacist who does that. For some projects, we have a workaround about that, and in 2 years' time, this national laws will go away because there's new EU legislation. But these 2 years are too big a time gap to just be doing nothing. And also, more importantly, we are faced with decentralization of government, and that's going on for some time now, and that will affect the organization of STI clinics. As I told you, we have 24 central municipal health services with some satellites, which are kind of difficult to manage in terms of uniform approach. But we will go to 400 municipalities in which this care has to be organized if everything goes wrong. We don't hope so, but you can't imagine how this can be organized. I can't. So we really, really hope that this is not going to be the case, that all these municipalities will have to share the bag of money which is available now. Well, there's maybe a positive thing about giving municipalities, or having municipalities be in the lead, because they may be able to reach certain key population, but they know best. But the subject, sexual health and STI, is usually not very high on the agenda of most of the communities or most of the municipalities. And on the negative side, it will never be a uniform policy. We will never have the data we have at the moment, and the chances are that they will all try to do the same thing in their own way. And I really believe in a public health policy which is centralized and which is firm, and we are lacking this at the moment. So in spite of the fact we have a national action plan, it's not yet endorsed by the ministry, and the funding is the funding we have at the moment, and we have to work very hard to get more if that's needed.
Silke, can you round up?
Sorry, I'm ready. So although these are maybe drawbacks, I still believe that because we have this history of working together for ages, maybe not, but for many years, I really hope that we will be able also in the future to keep that up and to fight for a good approach and for the realization of the goals in our plan. So, of course, in this approach, there are so many people involved, so I can't name them all, but I will thank them anyway. Thank you too.